May I request Dr. Chirag sir to please come on stage for the first talk of this session. Dr. Chirag will be discussing a new technique of treating PCL avulsions.
Good morning, one and all. And I would once again, on the outset, thank the organizers for the Masterclass Series 5. It's this season of the year which we all looking for this beautiful meeting. Very productive meeting with different ideas come together, and most of us execute this in our practice. This is something which I came across recently, and we thought we will probably share our technique, and probably this is due for publication sometime soon. 28-year-old IT professional, occasional badminton player, fall from bike 7 months back. Pain and instability while climbing stairs, PCL laxity grade 2, dial test negative. Patient who is a moderately active IT professional, plays badminton occasionally, moderately built, 7 months back injury, fall from the bike, direct impact into the knee joint. Now on X-ray, we have a stress X-ray here. X-ray, you can clearly see that there's a PCL avulsion, there's a grade 2 PCL sag. MRI shows a large fragment of PCL avulsed in toto and distracted well, probably about 3 to 4 millimeters of displacement, which is probably tried to be healing by fibrosis. On a CT scan, it's much more clear, it's much more displaced. There are a few small fragments, and there's one huge fragment lying down here, and the fragment is avulsed and displaced above the joint line. ARS question 1, 7 months old large fragment, PCL fragment, which is displaced, and attempt of fibrous healing with probably kind of a non-union. What would one do? Fix or reconstruct? 40% would fix and rest of them would...
So 60% would want to reconstruct?
60 would want to reconstruct. Okay. We went in for a fixation. Now assume we fix it. What would be the modality of fixation? Open screw fixation, arthroscopic endo button fixation, arthroscopic suture bridge technique. What is the preferred technique of the house?
Can we have the timer? Yeah. Okay, so it's a sort of mixed house.
Open screw
response.
fixation 33%, suture bridge technique 43%. Okay, it's the era of synthetics. Now we have gone through all this curve of screw fixation, intra-articular metal inside. We have done the suture bridge technique. In fact, we have published our own crisscross suture bridge technique 2 years back, which has been replicated by many of my colleagues. But we then thought, with that kind of a huge fragment which is displaced and which is probably gone into kind of a non-union, you need to have a strong suture bridge technique. It's like putting a noose around the neck and strangulating this PCL in the base, which would probably restrict your biology, and probably at that junction of the bone and the PCL at one point, it may give away. So our thought process was simple. We wanted to fix it. I did not want to open it. This was a big fragment. And we wanted to probably try out something new where we could get an indirect reduction and a kind of a ligament brace rigid fixation. So this is something which we have devised. We have used the synthetic ligament, which is commercially available in the market, and we have used something called the reverse Y or lambda technique. Era of synthetics, and this is one more indication where synthetics can be probably used, of course, intra-articularly. Shall I go to the technique per se? Yeah. So it's a standard procedure how I would do my any knee surgeries. Patient in supine with the bolster. The only thing what we do here is the portals are altered a little bit. The anteromedial and anterolateral portals are taken more towards the midline. A standard scopy, I'm viewing through the posterolateral portal and working through the posteromedial portal. Since my portal is in the center, it's very easy to open up that window between the ACL and PCL. I make that window and pass my telescope in this window to have an access to the posteromedial portal. Now, posteromedial portal, you make a nick. make an incision, introduce your 3.5 mm shaver and open up the septum, and then introduce a cannula in the posterior medial portal. Now, I usually do all my posterior work 4 portal. People are used to using through posterior medial portals. I usually use a posterior medial portal and a posterior lateral portal. All my PCL works are done with 4 portals. Now, our posterior lateral portal is modified a little bit, which my fellows in my OT call it the C portal. It's a beautiful portal with just a modification of the posterior lateral portal. I will probably extend my talk to this small technique of how you make this C portal or the modified posterior lateral portal, which will give you this kind of a bird's eye view towards your posterior compartment. Look at this, the posterior horn of the medial meniscus, the ramp, and the PCL seen so beautifully. It's very difficult to have this kind of access or vision with probably a posterior medial portal or an accessory posterior medial portal, or even with a standard posterior lateral portal. It's a small modification what we do here. You make your posterior medial portal. Once you have made your posterior medial portal, open up the septum and then pass the Wissinger rod. Now, this is how you would pass your Wissinger rod. The dotted lines, if you would pass your Wissinger rod transseptal in the same plane, it would exit out, giving you that kind of a straight trajectory, and then you'll have to turn your telescope, have a vision which is partially viewing your PCL and your posterior horn of your medial meniscus, so on and so forth. But what if you change the trajectory a little bit? Of course, you need to, if you change the trajectory, the chances of neurovascular injuries are also lesser. So what you need to do, you need to pass your Wissinger rod about 45 degrees superior and about 30 degrees anterior. You look at that, the plane, along with the plane of the shin bone or the tibia, you pass it about 30 degrees superior, your Wissinger rod, which you're passing from the posterior medial portal, pass it superior 30 degrees and superior 45 degrees and anterior 30 degrees, which will change the trajectory a little bit. You look at this, where the Wissinger rod is exiting out, it will exit out flush to the posterior cortex of your femur. And this is the kind of a view what you will get. The view from the C portal, fantastic. You can just stand, put your telescope in the front and work so easily. Just ask your assistant to push your monitor a little forward. You can beautifully see this kind of a picture. This has been my favorite portal to work with in the posterior part. You might as well repair your ramp like this. Difficult ramp lesions, your meniscotibial ligaments are seen so beautifully. You can have a very good access. You can put a couple of stitches here using the lasso if you want to do a ramp repair or the posterior medial capsular detachment. When you're doing your PCL, if you introduce a jig, this is how your markings of the jig would look like. You've never seen it before. And if you want to do any kind of a 2-tunnel techniques and all those things for the PCL, this is a beautiful portal. So I think most of us in the crowd will start using the C portal from Monday. So once we have done your portal, this is how I would work from. I'm viewing from the posterior lateral portal, that's the C portal, and working through my posterior medial portal. Now you see that a huge chunk which is partially fibrosed, displaced. Take your radiofrequency ablator, started debriding the fibrous tissues. Once the fibrous tissues were all debrided, this is what we found. Took an osteotome, it was stuck up, just released it gradually, titrated release, take a kind of a rasp or your curette and curette out, take a burr and you can just burr it out. This is what we did, like how you would freshen up any kind of bone surfaces since it's a chronic injury. And this is kind of a vision what you would get with the C portal. You can just easily work towards your from your posterior medial portal, viewing through your posterior lateral portal. Once you've debrided this, now how do we fix this? I have told you that I'm going to be using an indirect fixation, just like how we would use a crisscross suture configuration. You can make 2 tunnels by the side of the PCL, a little bit below and little bit adjacent to the footprint of the PCL of the avulsed fragment. Take your standard jig, make a portal on the medial side, make a portal on the lateral side to the avulsed fragment crater. Now once the crater is freshened well, this is the jig what is used. I am using the jig can be used either between your PCL and your femoral condyle or in that window what you have made between the ACL and PCL. My medial tunnel jig will be placed between my PCL and the medial femoral condyle. This is how I would visualize. Under vision, do not lose your vision here. You can introduce a Wissinger rod from your posterior medial portal and ask your assistant to probably retract the capsule there. That is the beauty of using the posterior lateral portal or the modified posterior lateral portal. A 4.5 mm drill bit used there, a cannulated drill bit. Once I have drilled there, I would just keep my 4.5 mm cannulated drill bit in situ. I will remove my beath pin and then introduce this Netlon wire. At this point, I will switch off the saline so that my Netlon wire passes easily. Take a grasper and grasp out this medial sided tunnel Netlon wire and place it in the medial compartment. Likewise, the lateral tunnel, I will use the jig between my ACL and PCL. I will go lateral to the crater and in a similar fashion use the beath pin, over drill it with 4.5 reamer, cannulated reamer, pass a Netlon wire and grasp it through my posterior medial portal. Now you have two Netlon wires, one in the posterior, both of them in the posterior medial portal, and they are parked outside. Now what do I do with this? Now I need to next prepare my brace. This is called the indirect reduction brace, a synthetic brace which is commercially available. The brace is long enough. We need to make three markings. One is that, assuming your PCL is about 35 or 40 millimeters in length. In shortest individual, you may probably have an interarticular length of 35. In longest individuals, you may have up to 42 millimeters. Depending on the height of the patient, you can just readjust this. Assuming you want 20 millimeters of this tape, just like how you do a reconstruction, PCL or an ACL reconstruction, using a flexible button. Now you want 25 millimeters into the tunnel, that is the first mark. Then you make the second mark at 45 millimeters. That means from the first mark, which goes inside 25 millimeters. After that, you will take 20 millimeters. The idea is to have a lambda kind of a configuration. Now you see that the first bit above the suture will go inside the tunnel. Between the first suture and the second suture is what is going to be intra-articular, which is going to sit over your PCL ligament, and the third part, which is free, it's like a slip, two limbs, which is like a Y configuration or a reverse lambda or a lambda configuration, is going to be sitting over the footprint of your PCL and over your bone fragment, and going to be indirectly buttressing and reducing your PCL fragment into the tunnels. I will then make a tunnel in the footprint of the femoral side and then introduce the ligament in this fashion. I will introduce the ligament through one of the portals. I am introducing it through the posterior lateral portal. The ligament with the button goes and sits into the tunnel which I have made in the footprint of the femoral side. Once that is done, you have the two limbs along with the central portion intra-articular. Now you need to grasp these two limbs with the grasper and push it inside towards the posterior portion or towards the posterior recess between your ACL and your PCL. Take a grabber and push it to the posterior aspect. Once you are done with that, now you have two limbs which are in the posterior aspect. You will now take your Netlon wires have already been retrieved. Sometimes you can lose that. And these Netlon wires will be loaded with the limbs which are sutured with the ethibond, and each one of these limbs will be pulled into the tunnel in a fashion so that the two limbs fall directly over your footprint. You will just see that in a bit, how it falls back, and this is how it will sit. The two limbs of your PCL. Now you can gently milk it and tighten it to reduce the fragment. Sometimes if the fragments are too displaced, you may need to maneuver it a little bit. You can take a grabber. This is the intra-articular portion in the femoral side, and this is the portion of the brace posteriorly. You can just use a grabber or a stong and maneuver the fragment so that the fragment sits well, flush, and you can guardedly tension this one by one to get a good rigid buttress of the fragment into the crater. Now you have two limbs of this. You can gently milk it and tension it according to your wills and fancies. You can see that my assistant is giving an anterior drawer so that This is fixed in anterior drawer position. You can either tie the two limbs with the bone bridge in between, or I would like to use this ligament staple and fix it. At the end of it, you have this step off, which is negated. Now, we did a CT scan at 2 months, and this is how it looked like. The bone tunnels, which are seen well here, the ligament staple is seen well, and the buttressed fragment of the PCL is sitting well there, right below the equator, and it is flush sitting down. Of course, we still haven't seen any union. This is at mild union callus formations is seen now. This is at 2 months post the surgery, and that's the 3D reconstruction scan, which is seen at 2 months with the fragment well seated in place. That was a small surgical technique of our indirect reduction and ligament brace fixation of the PCL avulsed fragment. And of course, a small note on the modified posterolateral portal called the C portal. Thank you.